Welcome to the Heart of Innovation, 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group thewaytomyheart.org in partnership with Cardiovascular System Incorporated's patient advocacy campaign, Take a Stand Against Amputation. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kym McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Hi, everyone, and welcome to the show. I'm Kym McNicholas, and I'm with Dr. John Phillips. Remember to call in if you are listening live. Join the discussion. Write this number down, 1-888-367-5329, 1-888-367-5329. Lock it into your speed dial. Today, we're going to talk about why veins are not always fun in the sun. We get so many questions from patients all over the world. Why do my veins pop out or look bigger in the summer? Well, we're going to talk about that and advanced treatment options for various vein issues that impact more than 30 million people in the U.S. alone, with only 10% seeking treatment, according to the Society of Vascular Surgeons. But first, before we get into the topic, before we review our week as we always do, Dr. Phillips, can you give us a little bit of motivation and inspiration?
Kym, good afternoon. Good morning. How you doing?
Hi. I hear you have some motivation for us. I need to hear it.
Well, I think we're going to start our episodes now with an inspirational quote. So I got this one from Marcus Aurelius, one of the Stoic philosophers. But I think it kind of centers around what we've talked about in our prior episodes about patient advocacy and being your own quarterback of your care. But this one, he says, you have power over your mind, not outside events. Realize this and you will find strength. So control what you can control.
Live an unconditional life.
That's right? Exactly right. Yes, indeed.
I think that's so important. When you live a conditional life, it can be so stressful and it can leave you with a life without hope. So yeah, that's not good. So thank you for a little inspiration. That really sets us up for a great show.
I'll do what I can.
Any interesting things happening this week? I mean, we had a really crazy week.
It's just we were talking before the show about telehealth and communicating with patients. And I find that more often than not, I'm giving them my cell phone and or at least the providers that I get referrals from. And just had it, on Thursday, I had a text from one of the docs saying, hey, Mr. So-and-so's leg isn't looking good. What can you do? And, thankfully we have pretty rapid access. So he's coming to see me Monday, I think, probably for an angiogram. So it's kind of nice to have the technology. And I was just reflecting on that when we were talking about that before the show, Dr. Hill.
Yeah, exactly. Yeah. We've been keeping Dr. Brad Hill with Hill Vascular down in Campbell, California, in the southern San Francisco Bay Area. We've kept him busy. He's on call this weekend, but he didn't expect to be on call last night with my dad talking about venous issues, swelling in the sun. I mean, talk about timing. And then this morning, our nurse practitioner, Kay, is looking at one of our patients with The Way to My Heart. We're a nonprofit organization that supports patients who have peripheral artery disease, restricted blood flow in the leg arteries, mainly due to plaque buildup. And he was on reviewing the case and making sure, hey, do we need to get in today or can it wait till next week? Sorry, Dr. Hill, it's your weekend, but you said you were on call, right?
That's right. That's what we're all here for, to help people. And so it's, you never know what you're going to run into. You wake up in the morning and a lot of people out there are suffering unnecessarily. And we have such great treatment options, in 2022. So it's just making the proper diagnosis and setting expectations and using all the technology, to its fullest extent to help people out there.
Yeah, no, definitely. I mean, even in just leading into the topic of the day, even with my dad, he has some venous issues, not sure exactly what's going on yet. You were fantastic in asking him all the right questions last night, but really, the summer heat can really make some of those vein issues a little bit more prevalent, right? Just like his.
Absolutely. I mean, people, during the summer, you want to get outside in shorts and walk around, enjoy the sun, be with your friends and family. and it's hot, and the legs get heated up, and the veins tend to pop out, and you're under the sun, so the shadows are being cast by the veins, and they're more prominent. You may notice them maybe a little bit worse this year than they were last year. Mm-hmm. So people really notice them during the summer.
And we also have a special guest, Professor Mark Whiteley. He is a consultant venous surgeon and executive chairman of the Whiteley Clinic in London. I think some people call you the celebrity vein doctor over there in the UK. You've even invented quite a few advanced treatments for veins. Anything notable this week before we deep dive into some venous conversations?
Nothing special this week. We were on television in the UK last night, which was quite nice. Thursday night, doing a case for the UK TV, which was very nice, called Embarrassing Bodies. So it's quite nice that the UK, we've got one of, as you know, some of the celebrities come to see us will let us use their names. So a very famous person over here called Chris Evans has been a fantastic advocate for veins. And he also had me on his show, I think on Tuesday. One of the nice things about that is he also, many people think that venous problems, especially varicose veins, are only female. And they think most people who get venous problems are female, and male, it doesn't really affect so much. In fact, a lot of research has shown it's prevalent in males and females to the same extent. Maybe a slight preponderance to ladies, but this idea of females having it 5 times or 6 times more likely than males is all just because in the past we've listened to doctors who say who comes to see you rather than gone out to populations and actually found who actually is suffering. So I think that sort of it's quite interesting that those two things have come up at once. That, number one, people are getting more used to it, and number two, there's this great advocacy for men to get venous diseases sorted out.
Right. One of the biggest issues, everyone's heard of varicose veins. Everyone's seen varicose veins. Do you find that most of these celebrities who are coming in are asking you to treat them because of the look of them, or mainly because there is a medically necessary treatment need?
I think that really comes down to the heart of what's changed in the last 20 years. And there's been a lot of research showing that if you look at what happens to varicose veins, they don't just sit there and do nothing. Varicose veins only appear because they're stopping inflammation at the ankles. They're sort of like the shock absorbers. And half the people with venous diseases don't see anything until they start getting the problems, which is swelling of the ankles, skin discoloration, ulcers, and eventually you can also get clots and bleeds on top. And something like 1 in 22 people every year who have venous problems will deteriorate to the next level, which is the swollen ankles, as I said, that sort of chain going. So we now know that everybody, if you leave it long enough, will actually end up with a venous problem. And a lot of, and I mean by that, not just things they don't look like, but something that affects quality of life. So it's really important that most people start coming with aching if they're sensible, but if they don't, then you get these other problems.
And coming up right here on the Heart of Innovation, we will go in depth on the difference between what you should get treated and what you shouldn't get treated when it comes to veins. So stay with us.
Leg health can indicate risk for heart attack, stroke, and amputation. If you have leg pain or cramps while walking, get checked for peripheral artery disease, or PAD. PAD is plaque buildup in mainly the leg arteries. Be sure to ask your physician for an ankle brachial index, also called an ABI test, where they use blood pressure cuffs to analyze the blood pressure in your legs. If they discover you have arterial plaque that's limiting blood flow to your feet, medicine and a regimented walking program are frontline treatment. If PAD is in its advanced stages, your physician may schedule a surgical intervention. Minimally invasive tools are available to remove plaque and restore blood flow, including Cardiovascular System's Diamondback 360 atherectomy system, which sands away plaque that is a hard calcium. It's important to discuss all options with your physician, and if told you have no options, get a second opinion. Take a stand against amputation. For more information, go to standagainsamputation.com. That's standagainsamputation.com.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for joining us. I'm Joined again here with Kym, and we have doctors Brad Hill and Mark Whiteley. And today we're discussing superficial vein disease or varicose veins. I treat them. We see folks that have varicose veins. A lot of times they're coming into the office to discuss treatment options. So, Dr. Hill, if I may ask, when a patient comes in to see you for a superficial vein that, maybe they're noticing more so now because they've got shorts on and it's warm out and they don't like the look of it, how do you start that conversation with them about, setting expectation or treatment options? What are your thoughts?
Sure. Well, I want to understand better, what their perspective is on this and what is the history. So oftentimes these patients will have a family history. They'll say my mother or father had them, my grandparent had them, and now I'm seeing these changes in my legs. So they're usually very concerned because they can relate to what they've seen around them and what happens to people as the veins progress. So we want to understand the history, what their take on it is, and then we really want to make a proper diagnosis. So usually this is something that manifests and is caused by some underlying problem. So the next step is to do an ultrasound to look at the veins in the leg, and most people don't realize the anatomy is basically a set of deep veins, which are the primary veins that carry blood back to the heart, and then the superficial veins, which are between the skin and the muscle. And so when people develop varicose veins, usually those are stemming off the superficial veins, and there's increased pressure and the veins will elongate and enlarge and they become visible. But it's a sign of an underlying problem, and we need to fully understand what that is. And ultrasound is non-invasive, very simple test that we can do to map out all the veins and look and see if there are any obstructions like clots or scar tissue that is formed in the veins, as well as the valve function that keeps the blood traveling in one direction toward the heart, which is the normal physiology. So we use ultrasound to understand what is the underlying situation that may be contributing to the varicose veins.
Yeah, when I'm trying to describe to some of our patients that we work with, we talk about, do you have a vein flap problem? Have the flaps failed? Or the vein flaps, have they failed? Are they just lazy? Do they need to wake up? Do you need to, treat them in some way to make sure you can usher, the blood flow going?
Correct. Yeah. So the faulty veins or valves, it seems to be a structural issue that there is a genetic component to that over time that can cause the veins to fail. And sometimes it happens early in life, even during the teenage years or early 20s, people will start having problems with veins appearing. When you get to about the age of 40, about 50% of people will have some visible changes. They may be little spider veins in the skin or larger varicose veins, but it's such a common problem and significant disease, just in the United States, 30 million or so, I think you mentioned earlier in the program, have some form of vein disease that's causing symptoms. Right?
Dr. Whiteley, once you make the diagnosis of venous insufficiency or the veins are kind of leaking, go through your treatment algorithm with us. I think someone had brought a question about compression, so kind of a non-invasive way of treating them versus some of the invasive techniques that we have.
Yes, Carol is one of the patients that is online watching the stream right now. So that was her question.
Nice.
So with venous reflux disease, there's three main causes of venous disease, of which valve failure is the most common, but you can also get stasis, which just is not the veins moving enough, or obstruction, which is blockage. With venous reflux disease, which is the commonest, there's most people think there's like 2 or 3 veins, the great venous, small venous, and some people talk about the anterior accessory venous veins that can fail in any order. In fact, there's over 150 veins on each leg that can fail, because you have all the perforators, you have pelvic veins. And so now it's become much, much more complex to give a simple answer, because it depends which pattern you've got. And when any of those ones refluxing any of those 150 can cause a problem, we know know that sometimes it's treating the pelvic veins. Often it's treating with endovenous laser, radiofrequency, or the new non-invasive ultrasound techniques like Sonovane. We can actually ablate or stop those veins from refluxing, and you have to modify it on the pattern. The most important thing I think to say is if you can walk and if you're healthy, compression has no place at all. And the NICE guidelines have actually said very, very clearly, as have the American Venous Forum, the guidelines, the compression should be only reserved for those people who can't be treated, because you can get people back to normality nowadays with the new minimally invasive techniques. So compression is really there for those people who can't have treatment or are immobile.
Fantastic. We are going to head to break just a little bit early. We come back. We have a lot more to talk about. We have several questions. I believe we have a doctor on the line that wants to join the discussion as well. And we will see you back here right here on the Heart of Innovation. So stay with us.
Medical Notepad, brought to you by patient advocacy organizations Take a Stand Against Amputation and The Way to My Heart.
Hi, I'm Dr. Lake Raja from El Paso Cardiology Associates at El Paso, Texas. What is an angiogram? First, it's only performed if the physician discovers through initial testing that you have peripheral arterial disease, restricted blood flow in the legs due to plaque buildup. The initial testing can be an ankle brachial index or ABI test, where they measure the differential of blood pressure between your legs and your feet using blood pressure cuffs, and or an ultrasound where they put a gel on your legs and use a probe to read the sound waves and see inside your body. Now, the angiogram is an advanced procedure that a vascular specialist, which could be an interventional cardiologist such as myself, an interventional radiologist or vascular surgeon, performs under an X-ray. An IV is placed with a light sedation. Once you are sedated, the doctor will use ultrasound guidance to locate an artery either in your wrist, groin, foot, or calf to insert a catheter. A dye is injected through the catheter into the artery to light up any narrowing or blockage in your legs. Once the doctor locates the blockage, he or she will decide how to restore the blood flow. Doctor can dilate balloons or push plaque aside. Some even have a drug coating on them to help prevent restenosis. That's known as angioplasty. There are devices that can be used to remove the plaque. They are known as atherectomy or thrombectomy devices, which are used for clots. Sometimes stents or a type of a metal scaffolding are used to hold the vessel open following the treatment. The newer philosophy is to leave nothing behind if you can help it. You definitely want to choose a physician that will try to use advanced treatment methods to limit stent use. But they are usually necessary in the groin and abdomen arteries known as common femoral artery, iliac artery, or aorta. An angiogram typically takes about an hour or two. If done in an outpatient lab, you are always home same day. In a hospital facility, if later during the day, you may spend the night. Recovery is minimal. You should be walking hours later, hopefully with less pain and warm feet. Sometimes you might feel what we call reperfusion pain. It's simply when blood flow is restored and you wake up the nerves and tissue downstream again. That should ease within a few days. With the basics of angiogram, I'm Dr. Lake Raja.
Medical Notepad is a series for educational and informational purposes only. Advice offered is not a substitute for medical advice from your own supervising physician. Do not act on any information provided in this series without the explicit consent from your own healthcare team. For more information on peripheral artery disease, go to standagainsamputation.com, and for peripheral artery disease support, go to thewaytomyheart.org.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
And we're back. Don't forget to call in 888-367-5329 if you have any questions. And we're continuing the conversation about superficial vein disease, so those kind of bulgy veins you see in your legs. And we were just before break discussing compression, which is a common treatment recommendation. And Dr. Whiteley, you were saying that maybe there's not a role for compression?
No, the only time you should ever use compression as a treatment is if the patient is unable to have surgery for any reason. There's no scientific basis for using it. We can now emulate the effects of compression by fixing the internal veins using endovenous techniques or these new techniques from outside the body with high-intensity focused ultrasound. So the NICE guidelines and the American Venous Thrombosis guidelines say very clearly that you should not use compression as a treatment option unless there's no other option, unless the patient doesn't want treatment or unless for some reason they're not suitable for treatment.
But maybe Dr. Hill and Dr. Phillips, correct me if I'm wrong, but here in the US, it's a requirement to wear compression socks. We had a patient that nurse practitioner Kay was working with for the Way to My Heart, and they said, go home for 3 months, wear compression socks. And she says, it's the middle of summer. You think I'm going to wear knee-high compression socks?
Yeah, I mean, maybe it's regional, but at least the patients that I see that have documented insufficiency or reflux based on the ultrasound testing that we were discussed, you have to wear compression for at least 3 months for most insurance companies to cover it. Dr. Hill, I don't know.
Yeah, that's exactly right. It's a requirement as a conservative measure for patients. And there are three main concepts here. One is walking exercise. And Dr. Whiteley just mentioned that if someone is able to walk normally, the foot and the calf muscles basically function as pumps to push the blood back up to the heart.
Right, we call it the second heart.
Exactly. So if someone's valves are working normally, then there's really no significant pressure. As soon as you start walking in the venous system, but if the valves are failing, then the pressure is going to be there as soon as you stop walking. So, but the insurance companies and the various, there's one company that requires a 2-week, they call it stocking trial before you can offer definitive treatment. But most of them, including Medicare in the United States, require a 3-month trial stocking therapy. So walking, exercise, leg elevation, and compression therapy are the three main principles for conservative management, short of doing an intervention. But we have such good treatments that are low risk these days that really anyone who is ambulatory and has normal capacity to walk, should seriously consider these treatments that can be done as an outpatient very quickly with a lifelong benefit by doing them.
And what are some of these treatments? I know, Dr. Whiteley, you also pioneered a couple treatments as well that are known around the world. It's important to know not only what are the treatments, but also what are the indications for the treatments. And it would be interesting to hear that in the UK versus that of the US.
Yeah, there's two main indications. There's the medical indications, and those have now been outlined in three major sort of international guidelines: European, English, and UK rather, and North American. And all of them agree that as soon as you have varicose veins and any symptoms at all, rarely pain, it's usually aching, heaviness, tenderness, tired legs, or swelling of the ankles due to varicose veins, thrombophlebitis or clots in the superficial veins, veins, any bleeding from varicose veins, venous eczema, redness or brown stains around the ankles, or leg ulcers, even if it's healed. All of those are medical reasons that you must have a venous duplex ultrasound scan, and if appropriate, must have treatment. The second cause, of course, is if you've got veins that don't have any signs or symptoms, you can have them treated for cosmetic reasons, but that's a personal one. And of course, most insurance carriers wouldn't cover that. But those are the two main reasons, medical causes or non-medical. I must say the one thing that's very interesting is most people who come to me thinking they've got medical reasons, by the time you've investigated them, they've usually got flecks of brown around their ankles, or they've got edema, the swelling of the ankles, and you actually find they've got medical reasons and just thought they weren't medical causes. And so many people have venous disease that's more advanced than they think because we've been led to think it's only cosmetic.
And Dr. Hill, Dr. Phillips, is that the same here in the US?
Yeah, I wanted to just touch base because, a lot of what we talked about, Kym, on our previous shows is patient advocacy. And, it's not uncommon for me to see a patient who has a clear venous ulcer that has been, quote unquote, treated for months. And once you kind of get to the nitty gritty of it, you find out that it is venous insufficiency. And Dr. Hill, right, we have a pretty landmark study that showed faster wound healing times with ablation techniques as opposed to just relative wound care.
That's right. And also preventing a recurrent ulcer. If someone's had an ulcer and they have superficial reflux or the valves not functioning, if you treat those veins, the chance of the ulcer coming back is significantly reduced. So one other thing I wanted to just mention about compression therapy, because, patients that have a treatable problem can avoid having to, rely on compression stockings for the rest of their life. But we don't want to give the impression that stockings have no use at all. So if you're going on a prolonged trip, if you're flying across the Atlantic, or if you're immobilized after an operation, there is a role for compression because, those are times when you're not able to walk, and those muscle pumps built into your body, the calf and the foot, are not functioning. Then you should wear compression to avoid a clot forming in the leg. So there is a role for compression therapy in circumstances like that.
That's a really good point. I actually had my first, trip from a plane to the ambulance to the hospital in Australia because of exactly that. And they put me straight into compression socks. Ever since then, I have to wear literally hip to toe compression socks.
I had a patient.
Really sexy, I'm going to tell you. No wonder I'm single.
A patient wears shorts with a history of a recent DVT, and he told me that he had flown from San Francisco to, I think it was Tokyo, and he purposefully requested a window seat and made sure that he was dehydrated so that he would not have to get up during the flight. And he just sat there in his seat the whole trip, and he got a DVT. So, you want to hydrate, you want to pump your legs when you're sitting there in the airline seat, et cetera, keep things going.
All right. And we'll continue the discussion when we come back from our break.
Well, hey, everyone. My name is Dr. David Alper, and I'm here once again with the WayToMyHeart.org's Footnotes. And today we're going to talk about pretty feet. Why are we going to talk about pretty feet? Well, because people do like to make their feet look good. It makes you feel better. It makes the feet feel a little better. But you have to do it properly. You have to do it safely. And especially if you have circulation issues like PAD or diabetes, some things can actually be more of a danger than they can helping you with the way your feet look. So let's start with toenails. Toenails, of course, are the same tissue as skin, which means the toenails need to be able to breathe. When you paint your toenails, there's nothing wrong with doing it for a short period of time. But what you don't want to do is paint your nails in May and take it off in October, because the nails aren't able to breathe, and this is one of the reasons that you get fungal infections in your toenails. And while this is not medically dangerous, it can hurt, and it's really quite unsightly. So you really want to take your nail polish off after about a month, give it a few days to breathe, and then reapply it again. The same thing is true with fake toenails. The glue that keeps these on does not let the nails breathe. Funguses don't like air, and so when you seal the nail, it's a perfect way to help funguses grow and make the nails brittle. So once again, if you're going to put something like this on, make sure you don't leave it on for an extended period of time. When you're cutting your nails, it's better not to use something like this, but something like this that allows you to go straight across as you're cutting. You want to cut your nails straight across. Do not dig into the corners. That's a way of causing an ingrown toenail. If you have dead skin on your feet, please do not take something like this out, because you're basically taking a cheese grater to your skin. It's sharp metal, and especially if you don't have any feeling in your feet, it's very easy to go too deep. Much better to do some type of a buffing stone or a pumice stone that will take the dead skin off without going too deep, and make sure you moisturize after you do this. If you have little lumps and bumps of dead skin, corns on your toes or calluses on your knee, padding it to make the shoes more comfortable is appropriate. But please do not use anything that says for corn removal. This works with an acid called salicylic acid, which tries to burn it off. And if you read the package under the back, the first thing it says under warnings is do not use if you have diabetes. The second thing it says is do not use if you have poor circulation. All these do is burn your skin. Much better to moisturize them or go to a podiatrist that knows the proper way of removing them. If you follow these instructions, your feet can be safe, your feet can be healthy, and your feet can be pretty. This is Dr. David Alper. For further information, please go to the American Podiatric Medical Association at apma.org, the American Diabetes Association at ada.org, and of course, thewaytomyheart.org. Thank you very much, and I look forward to seeing you at another foot.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Thanks for joining us, everybody. We're continuing our spirited and dynamic discussion about superficial vein disease, and we have a caller, Dr. Ginsberg out of Wisconsin. Dr. Ginsberg, can you hear me?
Once again, thank you for having me. And I think you guys have a wonderful discussion, and it's a great sort of idea of adequacy for wound healing, amputation prevention, and limb salvage. And the topic of today sounds like it's a superficial venous disease. So, in a context of superficial venous disease, I thought that it was a very, very interesting conversation about compression therapy and do you even try it or not. And I think that me practicing in the U.S., and as someone mentioned, Wisconsin, and I think it probably applies to multiple states, I think that there's also a differentiation in terms of if there's truly a venous ulcer or healed venous ulcer, where really at that point in time, compression therapy is not something we're going to go first line. We're going to go for the incompetent veins versus if someone has symptomatic varicose vein disease, that will kind of where insurance will necessitate initial trial of compression therapy, just like a little. So it is slightly differently when you have someone with a venous ulcer versus not.
It's really interesting that you mentioned the venous ulcer, and I'm curious what all of the doctors here have to say about this, because we had a patient in Michigan who ended up presenting with several ulcers, venous ulcers, and she was on deck for amputation. She was in so much pain. She called our Leg Saver hotline for the Way to My Heart, and said, I don't know what to do. I'm on deck for amputation, but I'm in pain, and today, and is this the right choice? So I called a world famous doctor, Dr. Jihad Mustafa, for peripheral artery disease, and he does treat some veins. And I said, hey, Dr. Mustafa, she's on deck for amputation. He's like, let me talk to her. He talked to her, but because of the pain, she ended up going straight to the emergency room. The pain can alter, your mindset a little bit and thinking that that's the only option. And 6 months later, so she did go ahead and get that amputation despite our pleas not to, and to get further testing and a second opinion. And she finally came to us and she's like, oh my gosh, they want to cut off my other leg. I'm having the same presentation of these ulcers and the pain, but I can't survive if I have two legs amputated. I said, would you finally go to Dr. Mustafa? Dr. Mustafa got her permission, called me straight from their clinic. And he's like, Kym, it's not even peripheral artery disease. It's a venous ulcer. She should never have had the first amputation. And let alone, they wanted to have her on deck for another amputation. Have you dealt with this?
I And I'll let the other physicians chime in, but I've never heard of a patient needing an amputation for a venous ulcer, unless if there was some other kind of thing going on. But again, it's important, like we've talked about, it's important to delineate between, is it peripheral arterial disease? Is it venous disease? Is it a mixture of both? I guess the question that I'll pose to our other physicians on the show is, if you have somebody that has both, they have peripheral arterial disease and venous disease, but they have a venous ulcer, I typically treat the peripheral arterial disease first to allow for compression and then venous ablation after that. Thoughts on that?
I'm so glad you asked that question. Go ahead. I also very similar thoughts, and really it's especially if the ABIs or the ankle brachial indices, which is an indication of how severe the peripheral arterial disease, and you have a mixed venous and arterial ulcer, or even if you have a typical venous ulcer on the medial malleolus, but they do have an underlying peripheral arterial disease, I also go and try to revascularize them just because I want to maximize compression therapy on my way to try to subsequently address their superficial venous insufficiency.
Thank you so much, Dr. Ginsberg, for your thoughts and for joining us. Any other doctors have any thoughts on either?
Yeah. If you follow just both science and logic, the simplest way, if you really don't know the difference, and quite often the new tests will tell you amounts, but they won't give you a comparative between the two diseases. The simplest thing is put the patient into bed, subcutaneous heparin so they don't get DVT, elevate their legs. If it's predominantly a venous ulcer, it will start to heal with elevation. If it's predominantly arterial, they'll be in agony because they're not perfusing the periphery. And it's the simplest test in the world to do, provided you've got a bed where you can look after them for 5 to 7 days, and it's the most accurate test. It will tell you absolutely categorically which is the most important part, whether it's arterial or venous.
Right, and I completely agree with all the comments being said. We're seeing more and more of these patients with mixed arterial and venous disease, and making the diagnosis and making sure they have adequate blood flow to heal, very critically important, and then dealing with the venous component as well. One other thing that we are seeing occasionally, and it's only 1% or so, or maybe less, is autoimmune vasculitic type wounds that can happen in patients. And these are related to the immune system actually attacking the patient's tissues and preventing healing. These are autoimmune dermatitis type wounds, and they're very, very painful for these patients. And they're treated with steroids, actually. So, having the proper team to make the diagnosis, and if there's no arterial disease, you're treating the venous problem, which you assume is a venous stasis ulcer, you're not getting results. We have to think of an autoimmune process that can be treated very easily with steroids and make a huge difference for these patients. Rare condition, but it does happen.
And we will be right back with more on the Heart of Innovation.
3 years ago, my symptoms started with leg pain and leg cramps while walking.
Me too, with a tightness in my calves.
Well, do you know, my doctor thought that my leg cramps were a side effect of the statin he prescribed me.
Well, my doctor just brushed them off as another symptom of old age.
Mine thought the pain was radiating from my spine.
My doctor blamed my neuropathy on diabetes until I got a wound on my foot that just wouldn't heal.
Yeah, it turns out we all have peripheral artery disease, also known as PAD.
It's plaque buildup mainly in the leg arteries causing poor circulation.
For me, the diagnosis came too late and I lost my leg, but that does not have to happen to you.
No, it does not, because there are treatment options available if you're diagnosed early enough.
PAD. Peripheral artery disease. If you've been experiencing leg pain, leg cramps, or neuropathy when walking, and your doctor isn't hearing you, we are. We are The Way to My Heart, the largest support network for peripheral artery disease patients, and we want to help you get back on your feet again. Visit our website at thewaytomyheart.org or call our Leg Saver hotline, 415-320-7138. Your life and limb could depend on it.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back. We only have just a few more minutes here. We're talking about venous disease, and it's becoming more prevalent, especially in the summer heat. But, as we were speaking over the past hour about the issues related to veins and the possibility there are treatments out there for them, there are critical questions that you do need to ask your doctor about any sort of venous issue before you seek any sort of treatment. Dr. Bradhill, I want to start with you just because before the break you were talking about, you could have gone in, they had a vein problem. Let's just ablate it. But whoa, hold on. That might be a Band-Aid. Actually, that might exacerbate the problem. We need to find out what is the medical reason this is happening before we treat.
Absolutely. It's so important to make the proper diagnosis before we start doing treatments. For example, the most common treatments we do are to close the superficial veins that are problematic. But for example, you want to make sure the deep veins are normal, because if you have obstruction or old clots causing lack of blood flow in the deep veins and you close off some of the superficial veins, it can make things worse. So you have to make sure that you get the proper diagnosis before any treatment.
Thank you. And Dr. Whiteley?
I think you also have to think as well that veins take blood all the way from the toes to the heart. And most vein doctors still only think about the veins going wrong or refluxing between the toes and the groin, and they forget all of the veins in the pelvis. And pelvis congestion syndrome, which is varicose veins of the pelvis, is turning out to be a major cause, because when that causes reflux, it goes back into the legs as well in many patients. And our research has shown 1 in 6 women who present with leg varicose veins and 1 in 30 men actually have their varicose veins in the legs coming back from the pelvis. And if that's not addressed, those varicose veins keep coming back no matter what treatment you do.
What is the test for that?
The best one in the world is a thing called the transvaginal venous duplex ultrasound, performed by the Holdstock-Harrison protocol. And things like MRI or CT, the trouble with that, you're lying flat and you can't see blood reflux. You only see size of veins. So you want to see a dynamic test with the veins refluxing.
Thank you. And Dr. Phillips, final thoughts.
Again, I agree with everything that's been said. A fantastic show. I think hopefully everyone's learned something. I certainly have. And, my final thought is to quote or to continue, reiterate the quote from Marcus Aurelius: you can control what you can control. And as, we're patient advocates, we want the patients to be the quarterback of their care. So ask the right questions regardless of your disease process.
And if you need to know which questions to ask, I am in direct contact with Dr. Phillips and Dr. Whiteley and Dr. Hill. Even nurse practitioner Kay Smith is always available to answer your questions. You can go to thewaytomyheart.org and you can submit your questions there, and we can make sure that all of our doctors and our nurse practitioner can help you to either one, find the right answers, or two, provide you with the right questions to ask your own healthcare team so that you can live a better quality of life. We really appreciate all of you joining us. Thank you to Drs. Mark Whiteley and Dr. Brad Hill. We really appreciate you being here. My co-host, Dr. John Phillips, and of course, nurse practitioner Kay, who's always in our groups and helping to support all of our friends around the world who need any sort of support with peripheral artery disease or venous disease. And thank you to all for joining us. For more shows, go to theheartofinnovation.org, and we'll see you next weekend.
Thanks, everybody.
You've been listening to The Heart of Innovation with Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips. Our mission is to help patients live a better quality of life through comprehensive education, real-time support, and high-touch advocacy in partnership with thewaytomyheart.org and take a stand against amputation. Our purpose is to reduce the 1.5 million heart attacks and strokes and nearly 200,000 amputations annually. For more information regarding topics you've heard discussed on today's program, go to theheartofinnovation.org. That's theheartofinnovation.org. The Heart of Innovation is for educational and informational purposes only, and advice and views shared are not a substitute for medical advice from your own supervising physician. Do not act on any information provided in this show without the explicit consent from your own healthcare team. If you think you are having a medical emergency, call your local emergency number or go to the nearest hospital or emergency room.